Hello everyone, Jamie McGumple here at Mayo Clinic to discuss this 48-year-old woman who presented with an upper airway obstruction and an incidental mass found in her right cavernous sinus. This was performed on CT neck and ultimately confirmed on MRI, a 3.4 centimeter lesion. Lesion is T2 hyperintense and rapidly contrast enhances. Chondrosarcoma versus cavernous hemangioma were thought to be in the differential. Through a variety of dynamic contrast exams, especially photon counting, our belief was this cavernous hemangioma. However, the patient did want a biopsy, although we did offer radiation up front. Therefore, endonasal biopsy to separate the tumor from the pituitary gland was chosen. You can see here a white line in the middle of the fields, suggestive of the medial wall push medially and compressing the pituitary gland. Here we're using intraoperative ultrasonography to explore the lesion, and note that it is not heavily filling as we'd expect it to despite the contrast enhancement. Here we expose it after we had injected, and it has blood supply to it clearly, but it's easily manageable, more of a venous blood supply, and obviously very red and soft but blottable, not suckable. You can see there the edge of the pituitary gland underneath the dura, and this tumor again itself is kind of stringy and compressible with the pituitary gland just to the left of the screen there where the dissector is pushing it away. Here we're working the pituitary gland and the mass off of it. You can see the upper portion of the diaphragm with a small leak where this must attach or insert to there. But most of the medial wall of the cavernous sinus is pushed separating this lesion itself in the cavernous sinus from this. Here we're going to cut it away from that upper diaphragm insertion all the way back to the posterior clinoid. We're going to get underneath this as the paraclavicle carotid is pushed quite a bit laterally, although we have to worry about it right in that region. We performed ultrasonography prior to doing this. You can see that we're able to actually manipulate the mass quite well. We are monitoring the sixth nerve through the course of this case in order to ensure we do not have any damage with it. As we kind of slowly work the edges, we're able to ultimately take out a fair proportion of the medial aspect of it. You can see, again, bleeding is quite minimal with this and ultimately be easily controlled with injectable gel foam. But at this time, we'll take this final piece for biopsy. We've created space from the carotid, which is just above where we're bipolaring there, to the pituitary gland. And then our also plan is, given this patient had a high chance of perioperative pituitary failure radiation, was to place fat in between this in order to separate it for treatment. There's the posterior clinoid, a small little portion of tumor there just above where the inferior apophyseal artery is. We actually preserve the inferior apophyseal artery in this case. We're going to short-term fill that with that liquid gel foam, get some good hemostasis, although again that isn't difficult. Then we'll place small pieces of fat in here to separate this to ensure that the radiation has some therapeutic distance overall. They had that small CSF leak, but we still put a small patch graft over the top, given the overall repair and fat placed within it. And this is the result of that surgery with a nice separation from the pituitary gland and the mass. Thank you for your time.